I hope what you glean today is that it's not just going to be hospitals anymore. We're going to talk a little bit about the delivery system, and it's not just going to be hospitals that are ruling things when somebody comes to the hospital. It's going to take the community. It's going to take patients. It's going to take physicians in the community all together to be able to reach this new, and I'll talk about the triple aim that the federal government and that we are working towards. We are in the midst of the largest change in healthcare in our livelihoods, and probably since Medicare was created. And Maryland is on the forefront. We've all heard about the exchanges, but Maryland is on the forefront of this in terms of healthcare delivery reform. We've already done some of this, and the United States, across the United States, are looking at Maryland to see whether we can achieve success. We've already seen some of that success. I've had meetings with folks from France and China and Dubai, Germany, and other places that have come here to ask us how we're doing what we're doing. So we're being looked at not only in the United States, but also nationally. Next slide, please, Suzanne. Thank you. So, as someone mentioned before, we've heard about the Affordable Care Act, and most of the attention has been on the exchange that Vinny was talking about. And obviously we've seen some great success there. But there's really a whole lot more in the Affordable Care Act than insurance reform, and that was some of the concern of Congress, was that we're just changing insurance, but if we don't deal with delivery system reform and the provision of care and the silos that take place across healthcare, then yeah, we'll have a lot of people insured, but the cost and quality will not improve. So there are some little known, if you will, provisions that in the Affordable Care Act that created the Center for Medicare and Medicaid Services to do some demonstration projects. Maryland now is for delivery system reform and payment reform. Maryland is the largest demonstration project in the country. So we're proud of that. And we believe that we've already shown some success, and we believe we have a lot of success down the road. The next slide. So what I wanted to show here in this slide is what the context has been over the years. And you all are so familiar with this because not only are you community leaders, but you're also patients. And when you go to the hospital, I'm sure that you've seen this. There's been huge nationally, huge fragmentation. There's silos between different healthcare providers, different insurers. There are no standards, and payment structures have all been different. And the providers don't talk to each other, or they necessarily don't have systems so that they can share information about patients. There's health nationally and in Maryland, there are of course large, inexcusable access and outcome issues and health disparity issues that need to be addressed. We all know the aging and the sicker population. John Comer's, our chairman, calls it the pig and the python, where now you have many people being eligible for the Medicare program and with higher cost and many chronic illnesses. The costs are going to be higher and costs are going to be driven much higher. Coverage and access, we have addressed a lot of this thanks to you and Vinny and many people in the community, but there's still a lot of people without health insurance. And there are still a lot of people that have a card today and don't necessarily know what to do with it and how they can use it to their best advantage. There are workforce shortages. The average age of RNs today is in the 50s. So many of these RNs are going to be leaving the industry, and we have more people who are going to need care. Same thing with many physicians, family physicians, primary care physicians in the community. There are many shortages around the country and in Maryland. And of course, without saying, high cost. We've seen tremendous increases in cost. Next slide, please. And we have more challenges ahead. As I mentioned, the aging of the population. In 2010, there were 40 million folks age 65 and older. Well, by 2030, that will almost double. What that means is there are many entitlements in the federal budget, and that is just going to increase the cost for Medicare in the federal budget. Who pays for this? We all do. We all pay in our taxes to support Medicare and to support Medicaid through the federal program. So we have to be interested. This is a journey together, and we all are playing and have a stake and are going to be playing a role. Next slide, please. Cost. I didn't add a slide here about nationally quality. When we compare ourselves nationally on quality and outcome, the United States does not do well. Well, on costing here, the top line, if you can't see it on both of these charts, is the United States, and it compares us on growth and cost compared to developed nations. And you can see, first of all, on the left side, that costs are much higher per person, and it's growing much greater than all of the developed countries. And it's swallowing up a larger portion of the gross domestic product, 18%. And these are 2009 numbers, and I know that they're much greater if you put that out to current time. Next slide, please. So one of the things that we've been focusing on, a lot of these costs relate to chronic conditions. And so we've had a major focus on how to deal with chronic conditions. And obviously chronic conditions is not just a hospital thing. Keep in mind, we regulate only hospital rates. But chronic conditions is a holistic approach to healthcare, not just when somebody gets to the hospital. So this is the area that hospitals and we as regulators have been really focused on. 1/3 of the population of the United States suffer from chronic diseases. 70% of deaths are a result of a chronic illness or disease. And if on this chart here, excuse me, on the bottom, it goes from, in the blue here, are folks in the Medicare program that have one chronic condition, and at the top, the purple, are those folks that have 6 or more chronic conditions. Well, 14% of the Medicare beneficiaries have 6 or more chronic conditions and generate more than almost 50% of the Medicare spending. This is where all hospitals and regulators are starting to pay a lot of attention to try to address both quality and cost. Next slide. So we also want to look at Maryland. We've been talking nationally right now. We want to look quickly at Maryland and Prince George's County as well. So you can see we picked out a couple of the major chronic conditions. Diabetes, obviously, is one major issue, one of the major chronic conditions. Nationally, 27% of Medicare beneficiaries have diabetes. The solid line is the national average. The dotted line there is the Maryland average. And you can see circled here is Prince George's. Maryland is of course higher than the nation here by a bit, but Prince George's is quite a bit higher than both the nation and Maryland. So diabetes is an area, of course, in Prince George's County that needs focus so that we can improve population health. The next slide here is for high cholesterol. 45% of Medicare beneficiaries nationally have high cholesterol. Maryland is much higher in high cholesterol. But Prince George's actually does pretty well on this chart, and they're below the nation and below Maryland as well. The final chronic condition is for high blood pressure, and 55% of Medicare beneficiaries have high blood pressure nationally. Maryland again is higher than the nation, and Prince George's is kind of in between, slightly higher than the nation, but does a little better than Maryland. So the next slide. This is what we've been talking about and what is written into the Affordable Care Act. It's the triple aim. I'm sure many of you have heard about the triple aim. What that means is that it's improving health of the population, it's improving health care, and that's where a lot of delivery system reform comes into place. And it improves cost, per capita cost. Now in the old days, we'd be really happy just to achieve one of these things, but the Affordable Care Act says you need to achieve all three of these things. And that's the goal from our perspective in terms of regulating hospitals in the state of Maryland. And U.S. is grappling with this, and as I mentioned, is looking to Maryland as a potential model. Next slide, please. So when we started to address this, there are really kind of 3 phases, 3 years that we're looking at. The first year is where we've been looking at a more consumer-centric model, understanding what consumers need, what they want, how we can address their needs, not just when they're in the hospital. And we've made some payment reforms to address that, so that hospitals have now an incentive to not only look at patients when they come to the hospital, and then when they leave, they're gone, but to look holistically, ensure that patients get treated for diseases before they come to the hospital so that they don't need it, and that they have care in the community when they need it. The second year, we're going to be modernizing some of the services to match the new model. And part of this forum here today, and the many forums that Vinny's putting on, is kind of partner with hospitals and physicians and community leaders across the state to try to bring everyone together under the guise of population health. And finally, and we've begun the focus on care coordination. That is the coordination of care when someone leaves the hospital, and have the hospital being involved in trying to help that person navigate through the community health and get their appointments, be able to keep their appointments, take their meds, get their meds. And I think a key part of this that was actually surprising to me is that there are a lot of social issues, social determinants that are barriers to people accessing care. And these are things that hospitals are going to start to look at as well. So the next slide. Again, we regulate the rates of hospitals. And what the new model does for us, in a nutshell, is it moves us away from this old volume-based fee-for-service model where hospitals were glad to see you come in the hospital because it's more money, to one where they actually treat you as a patient before you come to hospital and after you leave the hospital. So rather than getting paid for the more you do, the more you get paid. Next slide. The incentives have been changed to instead provide the better you do your care, the better you get paid, and there are incentives for that. The hospitals are at risk for population health and providing better care. And we need integration and collaboration with providers in the community to be able to do that. Next slide, please. So who are we? We are the Health Services Cost Review Commission. Yes, we've been around for 70 years and we have all kinds of successes to talk about. But it's a new day. We have a 7-member independent commission. John Comer, you may have heard of, was former Department of Health and Hygiene Secretary, is our chair. We work in a public utility model in creating rates based on cost. Everywhere else in the nation, when a hospital charges you, it may have absolutely nothing to do with cost. But here in Maryland, because we are a state entity, we're kind of a watchdog and we're a regulator, we make sure that the rates are reasonably related to cost. And we provide oversight to hospitals. Maryland hospitals, since the 70s, have been waived from Medicare payment rules as a result. And Medicare and Medicaid participate and pay the rates we set, not the rates that they set nationally everywhere else. And all payers participate in this, meaning all payers pay the same rates for the same services. And as I mentioned, this is unique in the country. Next slide, please. And what has this done? It's held down cost. It's provided access to care. We include the cost of uncompensated care in our rates, so there's no reason for a hospital to dump someone or not accept someone because they don't have insurance. It's built into the rates based on a reasonable amount. There's transparency. You can find out on our website a lot of stuff about hospital, how their quality is on various procedures. And all their data and finances are provided to the public. You can access that on our website. We've been a leader in quality. In fact, the federal government has been looking at us on our quality measures to try to copy some of those. So a big part of our requirements is we adjust payment based on a hospital's performance on complications, for example, and readmissions. And hospitals have local access to us as regulators, and so does the public, rather than having to go to Medicare. Good luck trying to get a meeting with a Medicare official. Next slide, please. So we have a new agreement that started January 1st, this new demonstration project with Medicare. It's focused on holding down costs, the growth in Maryland, and even more importantly, to improve quality. We have, as I mentioned, rewards for quality outcomes. And it encourages a lot of teamwork among the whole system. Hospitals, again, can't just act alone. They need to partner and collaborate and coordinate with the community. Next slide, please. What are the implications for patients and families? We expect to have much better quality safety scores, and the hospitals are accountable for that. And hospitals now are going to be more patient and family-centered. Expect greater care coordination. You're going to have hospitals, when you leave the hospital, they're going to be, maybe providing you your meds right there, or they're going to help you get your meds when you leave. Help you do better discharge planning so you understand why you were there and why you're leaving and what you have to do next. These are very important things to hospitals. Expect then more outreach from the providers after you leave. If you need help in your home, if your conditions are caused by issues in your house or lack of transportation or whatever it may be, hospitals will have an interest to make sure that you can access those things. And moving the care to really the most appropriate setting. The hospital is not the best place for all types of care, particularly non-acute care. We want people for acute care to be in the hospital. But if you're not sick, there are a lot of sick people in the hospital, believe it or not. And it's not necessarily a safe place to be if you're not sick. There should be access to the community. Hospitals should be helping you to access that. Next slide. So, before I get to the concluding thoughts, I wanted to tell you, we have been doing this model. We've been demoing this model for 4 years, what we call total patient revenue hospitals. You don't need to, I'm not going to go into what they are, but the idea is we've had huge success in rural hospitals around the state with our new payment model. They've seen better quality results for patients. They've been collaborating with their community. Their costs have been declining, and at the same time, their profit margins have been reasonable, have been increasing. So we've been able, in a small sample, to be able to have success on this triple aim. Let me give you a couple examples real quick of some of the things that they're doing. In some areas, nursing homes in the area may cause a lot of readmissions and complications because there are people who tend to come to the hospital frequently. Or they may come for hip replacement, knee replacements, and things like that, fairly common. One of the things that some of the strategies that hospitals are using is actually placing a nurse practitioner at the nursing home to do rounds there after someone has had a hip replacement to make sure that they're doing okay, they're taking their meds on time, they're seeing their doctor, and really helping those patients through that process. What that will do is reduce readmissions, much better for the patients, reduce the chance of coming back for a complication. This is all really good for patients, and that's our goal, is to improve patient care. Another example, in Western Maryland and Washington County, one of the hospitals out there took over the school nurse program. Why did they do that? Well, they found that a huge portion of their admissions, which were really unnecessary, were for asthma, kids with asthma. They actually took over the school nurse program and were able to deal with these kids at the source and help them. They even would go to their houses and say, if you had this kind of pillow, you wouldn't have the same kind of problem. Or if you had air conditioning in your house, and we'll help you with that. So there have been a lot of collaborations, and they're working. The message here, this is a call to action. This is a new day in healthcare delivery. It creates a path for change. It's less disruptive than what's going on elsewhere in the nation. This is proactive rather than reactive, both in terms of general health care, but also for the patient. We want hospitals to be proactive with patient care. And the new gold standards are not just how many people can we get the door and how much money the hospital can make. It's more about how well we can do on quality, providing appropriate hospital care, creating new partnerships, improving reducing the growth in costs. Costs will still increase, but not anywhere near the growth that we've seen in the past that outstrips our ability to pay from our personal income, and we'll have a population health focus. Next slide. So, well, thank you very much. I think we will probably have an opportunity for questions later, so I'll hand it over to you.